Okay, sorry for the delay. Thanks for coming again. Some new faces, some old friends. Today we have the honor to listen to Willem van Ommeren, renowned orthopedic surgeon from the Netherlands. And he's going to tell us a little bit about his experience of treating knee problems, cartilage problems especially. And a very interesting topic, I think, and see what we can learn from you today, right? Afterwards or in between, if you have any questions, don't hesitate to ask. As always, we like to interact and like to, as always in this session, like to ask questions and learn a little bit. All of us, we have different specialties, patients, physiotherapists, doctors, everything in between us. So don't hesitate, just ask questions. There's nothing stupid to ask and enjoy everything. The only thing is if you have a question, please let us know, and then we come with a microphone so that we actually all hear about it, and later on as well. Okay?
Yeah.
Enjoy.
Thank you, Misha. Thank you for the kind introduction. My name is Willem van Ommeren. I'm originally from Amsterdam, but I work in Rotterdam in the Netherlands, and I've been practicing as an orthopedic surgeon for about 25 years. And I was asked to present to you today on the topic of the knee. And the knee has been my field of expertise for the past, let's say, 20 years so far. And the topic that has gripped me the last years is especially cartilage. And cartilage is something that usually happens as a problem when you are young, like in between 30 years, after you've had a sustained trauma, and then there's nothing that we can do about it. Well, I'm going to tell you something that you can do. Everybody has heard about MACI, maybe, the problems where you can harvest cartilage and you can bring it to a laboratory and they will grow it back, and you have to do a second surgery to put it back in. Well, I'm going to tell you something about a new technique. Okay, first slide, please. This is the problem that we are facing. This is, if you look at this is what normal cartilage looks like, but this is a hole right here. And everybody has to tell their young patients when they're in between 25 and 30, there's nothing we can do about it. We had a technique that we called ice picking or condor picking, that you could make small holes. This is the pink area that you can see here, that's the bone, and then you could have regeneration of tissue that would mimic cartilage-like structures. But actually this was an end phase situation, so younger people were having pain at younger age, like 40, 45, and not being able to do sports or stuff like that. And that got people thinking. And what I want to take you into account is that we're going through the world of cartilage a bit and talking to you how we can maybe prevent this in the future. Next slide, please. We're going to talk about minced cartilage or autocart. This is not the best slide, but we'll get into that in a minute. Okay, next slide, please. The cartilage damage that you just saw looks like a pothole. Everybody has seen that on the roads here when they drove here, and you see all these markings right here, but this is the actual hole. Next slide. This is the cartilage defect that we're talking about. And just taking this as an example will probably enhance the understanding for the problem that we're dealing with. Next hole, please. This is what we call asphalt. Tarmac. This is what we need to put in to repair this. So this is actually what we are doing, putting in new tarmac into the hole. This is what we call the minced cartilage. And minced, as you probably know, is ground beef that you just slice into small bits. Not everybody's familiar with the English language, but this is making small morcellized particles that you can put back in. Next slide, please. And then you get a coverage of the road again so that you can drive across it again. Next case. So this is an actual patient that we did. You see the hole right there. What you see here in the cup is these are harvested small particles of cartilage that we took from the edges of the defect. This is then mixed with blood derivatives, We take 60 cc's of blood, we put it in the machine, we centrifuge it, and then we mix it with the cartilage and we put it back in. Next slide. And this is about after 6 months.
So like a PRP mix.
Not PRP. It is a PRP, but you get fibrin clot, and it's more than PRP. Okay? So this is what you get after a few months, almost cartilage-like filling of the defect. So this was the spot. So this was it. Now, let's continue. This is the actual case. Hole, cleaning out of the hole. We're trying not to disturb the bony surface, because if you disturb the bony surface as a surgeon, you will get bone regrowth, and you don't want to have bone regrowth. You just want to have cartilage regrowth. And then we fill it up with the small particles, as you can see here. And next one, please. This is what the actual patient at a follow-up second look surgery is at 1 year. So this is not a commercial talking about what we did. This is what surprises us every time when we do a second look surgery after 4 months or after a year, because it almost looks normal. Not in every case.
Do you know if it's as hard as normal cartilage, or is it different after 6 months?
We haven't done any biopsies, but Schatzman in Munich has done biopsies, and they show cartilage-like tissue. So if you put in your probe, your stick that you use to touch the meniscus and to feel it around, it feels almost like cartilage. So coming from here, going to there in under a year, and it's a cartilage-like structure. That's what we're saying. And we don't have the data yet for more than 5 years, but Schatzman has published on his 5 years results, and they're looking promising. Okay.
So in between that year, the patient has had a normal life?
No. What I did, I put the spoiler in first so that I could take you back to where we started, okay? But that's a good question, and we're going to address that in a minute. Okay? Sure.
Is this a similar kind of treatment to where they do the PRP plasma?
Going to address that in a minute as well. PRP plasma does, if you have a hole in the knee right there, you can do the PRP. What will happen is that you hope that somehow the thrombocytes will adhere to your bony surface and will give you a cartilage-like tissue after a few months. It happens in cases. But these are, as you can see, compartmentalized defects. This is not arthrosis. And what you're talking about is arthritic knees, I guess.
Maybe we need to talk later.
Yeah, sure. Okay.
I'm not sure I've got arthritis.
No, but arthritic knees are like, do you know the grades from 0 to 4 arthritic knees? Grade 1 is mild arthrosis, 2 more severe, 3 is severe arthrosis, and 4 is a joint deformation. Okay? Can we have the next slide? We're going back. Okay, if you go through history, and that's going to address your question, you can see that in '83 they already started with a rabbit model. They proceeded to a goat model. Then they started with cartilage chips in humans, but they looked at the costs. And then they found a study with OCD, where young people have large defects in the knees. They put back the autologous bone chips, and they had a good repair, but you can see it's only a small study. And Salzman, the one I just mentioned, has done the most research that has been published with that we see. Holtz from Hamburg has as well, and my colleague Pat and myself are going to publish a series over probably at the end of the year, probably 100 patients so far. So that's not too bad. Okay, next slide, please. So if you look at what we are doing, and this is addressing the PRP question and what we have. This is something that I stole from the Arthrex firm, so it's not a commercial. You need to get you can all remember the defect that we just saw. And you need to get it back so that you have a whole cartilage defect. So you need a matrix. That's what we call the minced cartilage. You need to have cells that are viable or that are alive, that can regenerate cartilage. So those are the cells that we harvest from the edges of the defect. So if you have a degenerative knee, if you're over 45 or 50, you usually have a degenerative knee, and there's not too many viable cells anymore. End of life knee. Sorry to say that, but that's fact. And then we administer growth factors that we take from your own blood. Next slide, please. And there you have it, PRP, platelet-rich plasma. That is what we use. Platelet-poor plasma we don't use anymore. And this is what the firm calls, but ACP is a commercialized name as a PRP. Next slide, please. So this is what it looks like, taken from your own blood, and this is after it's been in a cycle in the centrifuge for 3,200 cycles per minute for about 9 minutes. And then you get this. Okay? You get we have a new machine now that has ACP max, that's my end slide, and then we get a 2,200-fold increase of the thrombocytes. So white blood cell concentration will go down because you do the centrifuge, and the platelet concentration will go up. Why is it so important that the white blood cells are taken out? Because white blood cells will give you an inflammatory response in your knee, and inflammation is something that you want to prevent. You want to have regenerative cells. And in your platelets are small particles that when the platelet ruptures, it will give you a growth factor that will attract blood vessels to grow in and will adhere to the minced cartilage and give you cartilage new formation. Okay, please, next one. So, platelet-rich plasma, chondrocyte proliferation, proteoglycan production. This is probably the most important aspect because cartilage is derived of collagen, and it's not a collagen that we have in the skin or collagen that we have in any other part of the body, but it's a type 2 collagen, and we haven't been able to replicate collagen type 2. So that's always been the problem. They've tried to use rib cartilage, turns to bone. They've tried many things. They even tried to make cartilage after harvesting it and putting it into the laboratory. It will cost you about 20,000 to 30,000 euros per case just to have it grown. And it will take 2 surgeries, and it's very expensive, as you can see. Inflammatory response goes down. That's the key. Okay, next slide, please. So then we have these autologous cartilage chips. So it's your own cartilage, and you're your own incubator. So you don't need anything else. Just an arthroscope, a centrifuge, and some other materials that you need to use. So it's kind of cheap as well. That's good for us, good for the patient, not as good for the firms. Next slide, please. So what you see here is a tool that we use. This is what we call a shaver. A shaver is an instrument that works like a small burr, and when it will spin at a certain cycle, and it will. This is a sucker here. This will suck out the particle of cartilage, and we will have it in this sieve right here, and we take it out. Next slide, please. You see it right here. You take it out, and there's a small plunger, and this all what you can see is all the cartilage that we took out of the edges of the defect. Next slide. What happens then is we have these special devices that we use, and we make vibrant glue that we make with this one right here. We make it ourselves during the entire procedure. Next one. And then we have a cannula like this one or that one. Just took 2 for example. And with this needle and this plunger, we will put the cartilage back in. You don't fill the entire defect, you only fill 60% because you'll get overstuffing in the end after about a year. And this overstuffing will be a hindrance for people walking, and it sometimes gives pain if you put in too much. So
I understand it's only one operation, everything goes in one go?
one operation, arthroscopic surgery, daycare. And all you need is a shaver, and you need a centrifuge, and you need some other materials, but it's not an expensive operation. Next slide, please. So this is an actual patient. This is one of our first, and this is the only one that we did open. So we didn't know what we were doing. So what you can see right here, this is normal cartilage, and what you see here is a rather large defect. That's the...
How do you get these defects?
You get a defect like this when you sustain an accident, when you tear your ACL, or you bump your knee during sports. You fall over from a cycle, or you play football, or you play field hockey, or anything else. You can get this, or you jump and you have a terrible incident. This is the collector, and here you can see this is the actual harvesting of the stuff, of the cartilage right here. Okay? This is the second look operation, and there you can see that it has been nicely filled up 7 months after. Next case, please. This is an actual patient that my colleague and myself did. You can see here is the defect. This is the filled defect that we used with all the new cartilage, the minced cartilage right here. You see this is pre-op. You can see this is what you see on your MRI. This is a typical view. Most of the English people probably remember Terry Thomas, the in-between sign in his teeth. I don't know if the Germans have somebody like that on who's familiar. But you see there's a defect right here, and we'll come there to that in a minute, is that the defect is usually under-exaggerated on the MRI. It's usually much bigger. And this is after 4 months. It's already filled up. And you see right here, there's no bone whitening right here. Here you can see bone whitening. You can see there's something happening right here. This is what we call bone edema. And this is the tissue is regenerating itself. Next slide, please. Another example. This is where the problem is. 5 months post-op, you see there's almost no effusion anymore, and this is a normal filling. It is actually the same patient, but this is, and next one, please. This is from the lateral side. You can see here's the defect. This is the filling at 5 months, and you can see.
How long will it last?
We don't know. Oh. It's the only question that we cannot answer. We're hoping.
Have you had any failures to come back and redo it again?
We had one redo. We did that a month ago.
And after how many years?
1 year.
Oh, okay.
The first in 75 patients. But there will be more, I'm sure. Next case, please. So, what is, you see, this is some of the literature that we had. Happy to share it with you. Satisfactory outcome at 2 years follow-up. It's a possible alternative to standard autologous chondrocyte implantation. So this may be a new technique, may be the better technique compared to all those expensive techniques that we had. It's being next slide, please. It's being popularized in all throughout Europe right now, and it hasn't been done in Spain so far as we know, because the technique hasn't arrived here yet. It's Salzman, this guy right here, is published an awful lot on these procedures. Next slide, please. And this is what they're saying: it significantly improves knee function, quality of life, but only 12 months follow-up. So there's more and more literature coming out, and at the latest large European orthopedic meetings. There are 5-year results, 10-year results are coming up, and they look promising so far.
Is it at this moment only applied to knees or other cartilage as well?
Ankle,
Hands maybe?
I haven't tried it yet. Shoulder is not a weight-bearing joint, so the shoulder will probably be exempt from it. Ankle is being done and seems to work. And hip, there's no evidence there because the hip is a totally different anatomy and history of problems there. But they both work. But the knee has been more intensively researched compared to the ankle. But then we have to talk to Professor Nick van Dijk to ask more about the ankle surgery because that's his topic. Next case, please.
Can you do this right now in Spain without legal issues?
Yeah, sure. It's just a normal arthroscopy. All I need to do is have a shaver ready, draw some blood, and use the stuff that's available. Okay. You can just buy it off the shelf. Arthrex is an American company. Is licensed to work here. Is licensed to sell its products here.
It's ready to go.
It's ready to go. All you need is to have the right patient at the right time. And the right patient is something that we have been trying to discover, but we discovered that if you are over a certain age or if your biological age is over, there are people that are 55 plus that are biologically a lot younger than people who are 45.
But how do you determine if the cartilage cells that you use are valuable at, let's say, a 45-year-old?
We consult these patients at the outpatient clinic, and we tell them that the older you get, the less chance. So the chances that it will work is going to be smaller than somebody who is 35 or 30. But denying the people the possibility of a repair, that's something that needs to be addressed. There's no definitive answer for that. Can I have the next one? Next one, please. Next one. There have been scores. There's people are trying to get like everything in orthopedics. They're trying to get a score for everything. So they're trying to make a score, and I left this slide in. It's called the Mozart score. If you have the Amadeus score, you can leave it. It is not Mozart, but these are the scores by which we grade the defects. This is for scientific purposes only, but just to make it a more scientific talk, I put it in. Okay, sorry to. This is important for us to know. If you have an MRI of a patient with a cartilage defect, it is always underestimating the size of the defect. That's something we need, as surgeons, you need to be aware of, and as a practitioner in the field, the size of the lesion is usually larger, and that's something that we see every time we go in. Because what happens if you take your feeling rod and you feel, you start to feel the cartilage, but you usually feel that's already loose from the bony surface, and you have to take that out because it's viable, but it has no use, and it can become a loose body and give impingement, and then it gives you a problem. Next case, next slide, please. This is what I just have been saying. You can see this is a nice slide that says it all. This is underneath, and this is what you see on the MRI. Next one, please. Patient. This is a typical patient. This is in Dutch, so sorry for that, but lateral femoral condyle. Okay, next one. This is what I hope everybody can see. This here you can see a typical cartilage defect. This is what we call grade 4 because it's to the bone, all the way to the bone. That's a grade 4 defect. Next slide. Okay, you clean it out, you get a defect like this. You want to have sharp edges so that it will contain nicely. Next one. Then this is the applicator here. Okay, next one. And then you see through this needle and the plunger, you push in your cartilage, minced cartilage, what you have here. So all these small particles come out. And that's the hardest part. You have to place them inside the joint. You have to dry it out. And then you have to put on your fibrin glue, and then you're done. Takes you about 35 minutes.
When can they walk? Immediately?
We have them, we'll come to that in a minute.
Okay, sorry.
And this is the finished case. What we discovered, you have in your knee, you have Haffa's body zitten. Haffa's is a fat pad behind the patella tendon. And what we usually have, it's usually in the way of the surgery. But the fat is also what we discovered. If you leave small particles of fat inside, it can enhance the growth of the cartilage. So we leave part of the fat in. There's a lot of studies going on right now that if you have fatty-derived cells, that can enhance cartilage growth in your knee if you have a degenerative knee disorder. Fat stem cells work best. Next slide. This is also to show what we had. This is the patient with the defect, right there and right there. And this is about at 11 months. So it actually works. This is a colleague that works at a different institute from the same firm, but so we have a lot of evidence that it works. Different doctors, different surgeons. Next case, please. So these are with this new technique, we have so far had no complications, just one redo. We did no further harm. Patients were no worse off than they were before. We had a lot of subjective improvement in every case. We had objective improvement on the MRI in 85% of cases, and we did a second look in about 10 cases, so that was nice. We had to do revision ACL in 10 cases where we did the cartilage repair prior, and 4 months afterwards we had a chance to do a second look. Perfect. For academic purposes. Next case. So these are our own series. You can see that we're stretching it a bit to 50, but those were biological younger patients. And you can see there's a shift to most of the time it's on the lateral femoral condyle because that's the one that gets impinged most of the times during rotation trauma of the knee. We did a lot of additional surgeries. 30 cases were with an ACL reconstruction, 10 revisions, and we usually do a lateral a lameroplasty with the ACL reconstruction when we have a case like this. Next slide. So the take-home message that we have for the AutoCARD is it's a one-stage procedure. It's autologous. Short procedure, no extra time in surgery. Teamwork, well, that's... Next slide. This is the company. Next one. The after-treatment regime, that's what you were asking. Okay, next one. 4 weeks, partial weight bearing, maximum 10%, about 8 to 10 kilos. That's it.
Your own leg. That's their own leg.
Yeah. Thrombosis prophylaxis, important. From 4 to 6 weeks, partial weight bearing 50%, with walking with 2 crutches. After 2 weeks, after that, you go to 100%. We were allowing them to go to sports after 6 months, but after conferring with Professor Holtz from Hamburg, we went to a year because the cartilage is still in a maturing phase and it's too soft after about half a year. So we skipped that and we said, well, you need to at least, if you want to give your knee a chance to heal properly, to take care for about a year. Maybe it's too strict, I don't know. Nobody knows. Next one, please. This is all the literature that we have accumulated so far, so feel free. This is something like what you call end stride. This is actually the next phase in what you do. Is you take PRP, platelet-rich plasma, and you do another cycle in the centrifuge, and you get a higher concentration of thrombocytes with a better regenerative degenerative capabilities with patients with grade 3, 2, 3 problems, and it's been shown in a lot of literature lately that this will give you a in some cases, if you're young enough, healing of the cartilage, but it will alleviate the pain and will give you a comfort of about 4 to 5 years that you don't need knee replacement. And you can do this in, some people are doing it in the thumb, in the CMC1 joint, in the ankle, in the knee, and I've heard people doing it in the shoulder. That was me. Thank you for your attention, please.
Mhm.
20?
Nee, nee.